Doing well. Oops. 1 second, it's kind of freaking out because of the recording now. I have to unshare my screen. 1 second. One second here. Alrighty. Sorry. Okay, there we go. Well, thanks everyone for being here. So I'm going to talk this morning about a particular passion of mine, which is the intersection of human health, environmental health, and animal health. And I'm going to talk about this through the lens of emerging zoonotic diseases and pandemic preparedness, and kind of talk about a project that we've been working on to try to teach some of these concepts to residents and medical students. Don't have any financial disclosures or any conflict of interest to share, but I do think I have some conflicting interests, which I suspect many of you share as well. And that's something that I often think about in this conflict between how do we, safeguard both human health as well as the health of our planet. I think a lot of the advances that we've made in improving human health have come at a cost for the health of the rest of our planet. And so how do we think about kind of reconciling these differences? I remember when I was a medical student, kind of being shocked at the amount of waste in the OR after a single case. And it's estimated that if the U.S. healthcare industry was its own country, it would rank 13th in terms of carbon emissions globally, which is quite a shocking statistic. Roughly 30 pounds of waste are produced per patient per day in hospitals, and that's like roughly 5 million tons per year. So there's a lot of toll that the healthcare industry takes on our environment. And so how do we kind of think about these things? That's something I've often struggled with as being a physician and also someone who cares about the health of our planet. One of the ways I think that we can kind of reconcile this and think about this more clearly is realizing that human health and environmental health, planetary health, these things are not kind of dissociated from one another, that they're actually one and the same, and they're really dependent, interconnected. There's been a movement called the One Health movement that really kind of takes these three pieces, the human component, the animal component, the environmental component, and tries to think about ways that these things are intersected with one another. This is a nice framework that I like in terms of thinking about pandemic preparedness and epidemics in the One Health framework, but thinking about how human factors like population growth, healthcare systems, mobility intersect with things like urbanization, deforestation, travel, increasing pressures on the environment from agricultural production and the food trade, consumption of meat, things like that, leading to pandemics. I think we all think about this a little bit more in the context of the emergence of SARS-CoV-2, but it's important to think about this not only for pandemics, but for other kind of world health issues. The second movement that's come along is the Planetary Health movement, which takes kind of a broader focus of this and more of a systems approach. And whereas One Health, there's been primarily driven by veterinarians and people thinking about zoonotic diseases, Planetary Health has kind of more of an environmental science focus. Some of the factors that I like that they add in terms of this is a framework that the Planetary Health Alliance uses in terms of teaching planetary health, is thinking about these systems and how they're interconnected, and specifically the additional thinking about equity and social justice being really important in terms of these concepts, in terms of thinking about the populations that are at greatest vulnerability for the emergence of new diseases or environmental change and how that affects vulnerable populations, and thinking about kind of where we are in the Anthropocene and how we're in this new geological age where human activity has the strongest influence on our environment, and then thinking about these systems level thinking. So I'm going to try to talk about some of these concepts and use a case to demonstrate that. So sorry, it didn't show up for some reason there. Oh, there we go. So despite there being kind of lots of advocacy about planetary health and One Health and research in these areas, I think a lot of times as a clinician, it can be really difficult to think about what we can do that's really tangible in terms of in our day-to-day practice about integrating some of these concepts. And so that's one of the things that I've been thinking a lot about there are advocacy groups like Clinicians for Planetary Health or Clinicians for Climate Change that people can join. There are research opportunities to study these issues, but what do you do, day to day in clinic that can kind of help you think about some of these problems? And so I've been working with Peter Rabinowitz here at UW in the Center for One Health to think about how do we kind of teach some of these concepts to residents and medical students in a way that's folks over there to develop. There's a website that we've developed with different cases that are self-guided cases that people can go through about Planetary Health and One Health that have really a clinical context and teach clinical competencies in a real way. And so today I'm going to go through really combining two of these cases on emerging zoonotic diseases and pandemic preparedness that I prepared. We have a total of 10 cases that we're working on kind of with global experts in multiple countries and low middle income countries and globally. And so some other interesting topics like heat emergencies, pollution, climate change, other things. But today we'll focus mostly on emerging zoonotic diseases and pandemic preparedness. Some things I hope that you can take away from this talk is a better understanding of how globalization and travel create opportunities for pandemics. I think we're more aware of this in the setting of COVID-19, but something to still think critically about. Understanding how ecological changes and human-animal interactions contribute to emerging zoonotic diseases. So how does environmental change and the pressures that humans put on the environment contribute to emerging zoonotic diseases, and then applying knowledge of the human-animal interface of where these diseases emerge to identify and prevent emerging zoonoses. Some clinical competencies, knowing how to perform a comprehensive history and exam for fever and returning traveler, learning how to build a differential diagnosis based on animal context and environmental exposures, and then understand diagnostic testing for zoonoses and high consequence pathogens. Recognizing measures to ensure healthcare worker safety and coordinate outbreak response with public health is something that I think we're not often taught about, but something that's really critical if you're going to be a clinician that might be detecting, the index case for one of these emerging diseases. So this is a real case. This is 2008. You're in a clinic, primary care clinic, and you have a 44-year-old woman coming into clinic with a severe headache, fever, chills, nausea, vomiting, and diarrhea. She says that 5 days ago, she returned from a 2-week safari in Uganda. What else would you want to ask her? And so this is kind of in a morning report style. People just want to throw things in the chat or unmute themselves. But what kind of history would you want to gather for fever and a returning traveler with some GI symptoms?
Like exposures to things, water, that sort of thing. Like what did they eat and drink and all that?
Yeah, that's great. Yeah, so exposure history is key.
There's some initial stuff in the chat. Did she take malaria prophylaxis, eat anything unusual? From Priyanka. Christian is saying sick contacts, food intake, known animal insect exposures. And he wants to know if there's some blood in the stools. Roshan's asking, how high are the fevers? Are they daily or cyclical? And then exposure to animal waste products.
Awesome. Yeah, those are all great things. And they all kind of encompass different points of what I think are kind of the key factors for thinking about taking a good history for fever in a returning traveler. So some of the things you guys brought up are kind of the who. So, what is their, are they immunocompromised? What are their host risk factors? What kind of exposures did they have? The what, what were they doing, where they were traveling? Where were they traveling, thinking about kind of geographic risk factors where they were, what was the symptom timeline, thinking about these things like cyclical fevers and things like that. And then, did they have any, or were they taking prophylaxis? So I think thinking about these things, so the timeline, one of the things that's really helpful in thinking about the symptom timeline is that there's kind of this 21-day cutoff. So most pathogens have an incubation period that's less than 3 weeks. So this includes most arboviruses, hemorrhagic fever viruses like Ebola virus, respiratory viruses like SARS-CoV-2, rickettsial diseases. But then you have another set of pathogens that have a greater than 21-day incubation period. So this is like tuberculosis, malaria, brucellosis, protozoal diseases. HIV can be a little bit tricky in the setting that sometimes people might miss a diagnosis of acute HIV. And so there can be kind of a delayed recognition of that. Thinking about geography, so pathogens that are, more prevalent in sub-Saharan Africa, versus North Africa, the Middle East. Thinking about in terms of those areas where there kind of might be exposures to livestock, so things like brucellosis, or acute fever, Coxiella burnetii. These pathogens are usually transmitted people, butchering livestock, drinking unpasteurized milk, working in areas where there might be birthing of livestock and handling placentas, things like that. Thinking about other, emerging coronaviruses like MERS, thinking about things like in Southeast Asia, where there's maybe a higher degree of kind of arthropod-borne diseases like dengue and chikungunya, melioidosis, kind of causing a more indolent sort of presentation like tuberculosis, although there was a large, there was an outbreak of melioid in the United States from aromatherapy that had been imported this year. So kind of keeping things like that on your differential. Nipah virus, another virus transmitted from bats. It causes more of a neurologic disease as well as ARDS. Thinking about, the host risk factors, obviously, if the patient's immunocompromised, being at higher risk for certain illnesses. Thinking about kind of what contacts, whether they were sexual contacts, maybe they're around people with respiratory illness. And then prophylaxis is a really good point. So yeah, are they on malaria prophylaxis, but also checking to see if the patient has had all their travel vaccinations that they need. So like yellow fever, if they're traveling to Africa, Japanese encephalitis, if they're going to Southeast Asia, measles, meningococcus. And then I think exposures are always kind of the fun and interesting things to think about. So freshwater exposures, so things like schistosomiasis, leptospirosis, enteric fever, typhoid. Thinking about animal bites, so Bartonella, Henseli being the agent for cat scratch disease, rabies, rat bite fever, and then kind of insect-borne diseases. So I think you guys touched on a lot of these different things, but thinking about this framework I think can be really helpful. And then thinking about zoonotic diseases in particular, I think it's really good to take a really good detailed history of animal exposures. And that, again, you can kind of use this framework thinking about what factors are like direct contact. So was a patient bitten by an animal, thinking about animals in that way? Were they around animals that were being butchered, slaughtered, or birthing? So thinking about whether there could be an epizootic event. So whether there's been an outbreak of a illness among some livestock or some animals that people have been exposed to. And we see this with things like Rift Valley fever, which is a mosquito-borne illness, but can cause outbreaks among livestock and can cause fetal deaths for livestock, and people can get exposed handling placentas and things like that, as well as butchering. Indirect contact, so thinking about fecal oral transmission for many foodborne pathogens, soil transmission, environmental aerosols and dust. There was a huge outbreak of Q fever in the Netherlands from dust inhalation, kind of associated with agricultural production that a lot of people were exposed to. We talked about unpasteurized dairy and raw food, some of the host risk factors, then kind of environmental exposure. So water contamination and weather events. So large flooding events, we see outbreaks of typhoid, leptospirosis, cholera, and then laboratory accidents is something else to be aware of, thinking about the patient that you're treating and whether there could have been a lab accident, and if there's someone that might handle one of these pathogens, and then kind of vector-borne diseases, and knowing kind of what types of arthropods and insects people might be exposed to and the different pathogens they carry. So mosquito-borne diseases versus tick-borne, fleas, lice, and flies. So back to the clinic. So 2 days ago, she developed severe headache, chills, vomiting, and diarrhea. She took 2 doses of ciprofloxacin and developed a diffuse rash, but still is having ongoing symptoms. So that's her timeline. She returned to Colorado from Uganda 5 days ago, but hasn't had any other travel. Doesn't have any past medical history, no sick contacts that she remembers. She took Malarone, so was on malaria prophylaxis, had typhoid and yellow fever vaccines, and is up to date with her vaccinations. In Uganda, she went camping, whitewater rafting, visited villages, and viewed wildlife on the savannah and in caves. What do you want to do next? So what kinds of things would you want to think about in terms of kind of physical exam and diagnostics for her? and we can keep going when people think about that a little bit. So in terms of physical exam, so a comprehensive physical exam is really key to evaluate fever in a returning traveler. Fever and altered mental status indicating a medical emergency. Thinking about other kind of potential signs or interesting things to think about. So a pulse rate that's slow for degree of fever or pulse temperature dissociation might suggest something like typhoid fever or rickettsial disease. So this is known as Fagut's sign. It's something that can be present in a lot of infectious diseases. So it's not that specific, but it's something interesting to look for. You suspect with every degree of temperature increase in a fever that you have about 10 beats per minute increase in your heart rate. And so for patients who don't have that and have this kind of paradoxical bradycardia, it's something to think about in terms of kind of unusual infections. Looking for rashes, so maculopapular rashes are often present in many infections, patients with dengue fever, meningococcemia. So thinking about viral hemorrhagic fevers from patients that might have petechiae or hemorrhagic lesions. Lymphadenopathy is something that's also good to do. So it's good to do a good thorough lymph node exam. It's interesting that sometimes there can be an association where bacterial or parasitic infections might have more localized lymphadenopathy, so only in a certain location, whereas more generalized lymphadenopathy is more common in viral and fungal infections or non-infectious causes like malignancy. Abdominal exam, so hepatosplenomegaly is associated with many diseases, but thinking about malaria, visceral leishmaniasis, typhoid, brucellosis, Q fever, malignancy. Some diagnostics to think about, so getting a CBC with diff, looking for things like eosinophilia, thinking about parasitic infection, lymphocytopenia. I think it's something that we think a little bit more about in the setting of COVID-19 because of this association. However, thinking about other viral infections like HIV, dengue can also cause lymphocytopenia, thrombocytopenia, so dengue, HIV, thinking about sepsis and DIC. So many of the viral hemorrhagic fevers, the pathophysiology and the reason people are dying from these is because of DIC. And so having a really high suspicion for that, if you're seeing some kind of coagulopathy occurring, thrombocytopenia. Checking for elevated LFTs, which we'll talk a little bit more about, getting blood cultures, as we all know, but also thinking about notifying the lab if you're checking for certain infections. For things like brucellosis, there have been laboratory exposures where lab personnel have been exposed. So giving the labs a heads up if you're thinking about something like that. For malaria, doing 3 thick films or rapid diagnostic testing, depending on the hospital protocol to exclude malaria. Checking a UA with urine culture, which I know Mac's is going to talk more about UAs later today, but thinking about proteinuria and hematuria in the setting of leptospirosis. And then serology and nucleic acid testing, which is something that's good to think about. And it's good to think about getting an acute phase sample when a patient first comes in, as well as kind of an early convalescent phase sample later that you can compare later, because this could help you detect whether there might be antibodies for something that might turn out to be kind of fever of unknown etiology. It's good to have multiple sets of serum samples.
Seth, quick question.
Yeah.
What do you mean by a convalescent sample? What's the timing on that?
Yeah, that's a great question. Usually what we think about is kind of in terms of their symptom course. And so, a patient that's presenting kind of in the acute phase of and is having, the first onset of symptoms, that would kind of be the acute phase sample. As their symptoms start to improve and they're kind of seem like they're clinically doing better, that's when you would get a convalescent phase. It depends per illness in terms of kind of what that timeline might look like. And we'll talk a little bit more about that in the setting of this case here. But something good to think about. In terms of going back to the primary care clinic, so on exam, her vitals are within normal limits. She's very pale and fatigued. She's got decreased bowel sounds, seems confused, but the remainder of her exam is unremarkable. In terms of diagnostic testing, so her white count, she's very leukopenic. Her AST is very elevated at 9,000. Their ALT is elevated at 4,000. Her creatinine is elevated at 2.3. So she's admitted from primary care clinic to a local hospital. They're concerned about acute hepatitis. She's confused, she's nauseous, and she's vomiting. So in the hospital, she's given IV fluids and she started on doxycycline for possible leptospirosis. While diagnostics are pending, she's known to have pancytopenia, coagulopathy, myositis, pancreatitis, and encephalopathy. And so now we should kind of start thinking about our differential diagnosis for her. Just to clarify, so they're starting her on doxycycline. So what they're concerned about for her is Wheels disease or kind of acute severe leptospirosis. And usually that's kind of this triad of having coagulopathy, liver dysfunction, and renal failure, which she is showing signs of. And I think they were concerned with her freshwater exposures and travel history. But are there anything else that people are thinking about kind of giving this constellation, the syndrome that she's having, as well as maybe from her exposures and kind of her symptom timeline?
Ruth is wondering if there's any bleeding.
Yeah. So on her labs, it looks like she's having signs of coagulopathy and pancytopenia and things like that. They did not document any overt bleeding on her in terms of her physical exam that was done in the primary care clinic.
And Joe was wanting to remind ourselves if there was a rash.
Yeah, they didn't document a rash, but I think that's something we should be thinking about. Yeah, does she have petechiae given the degree of pancytopenia that she's having, things like that. But they didn't comment on a rash.
There's thoughts in the chat. Myositis is interesting. Makes me think of a parasitic infection, but I can't remember the association honestly.
Mm-hmm. Yeah, the myositis is interesting and something that there's definitely some organ damage that's occurring pretty diffusely.
Ruth is suggesting malaria or yellow fever.
Yeah, I think those are good things to think about. Yeah, especially thinking about yellow fever, other kind of hemorrhagic fevers, as well as malaria. And she was on malaria prophylaxis, but could she have missed doses and things like that? So for the differential diagnosis, I think things to think about first, think about life-threatening causes of what could be causing fever and altered mental status in returning travelers. So meningitis, so this patient should be getting an LP if they're able to tolerate that and it's safe. Thinking about typhoid fever, meningococcemia for bacterial infections, viral infections, so yellow fever, thinking about rabies, given her cave and animal exposures, viral hemorrhagic fevers we talked about, so Marburg, Lassa. Lassa virus is a virus that's transmitted by Mastomys italiensis, which is the multi-mammate rat. It's most common in West Africa. Rift Valley fever, more common in East Africa. Again, kind of mosquito-borne, but then people with animal exposures. Different arboviruses, Nipah virus being more common in Southeast Asia, Malaysia, and Bangladesh. Parasitic infections, so African sleeping sickness, so trypanosomal diseases, Plasmodium falciparum, malaria being the most deadly form of malaria. These are things that we should have on our differential for someone who's this ill, who's returning. By her exposure history in Uganda, thinking about infectious etiology, so she went whitewater rafting, so leptospirosis, which they were treating her empirically for, schistosomiasis, acute schistosomiasis being more consistent with her presentation versus kind of a more chronic version of schisto. Visiting rural villages, so malaria, Lassa, hepatitis viruses, arboviruses that we talked about. Crimean Congo hemorrhagic fever virus is another arbovirus that's also a hemorrhagic fever virus that is ticks are the vector for it, but people are exposed usually with like slaughtering livestock, and this is more common in Africa and Europe. Wildlife viewing in caves, so rabies, Marburg, and Ebola viruses. So testing was negative for leptospirosis, HIV, viral hepatitis, malaria, arboviral infection, schistosomiasis, and rickettsial infection. So they got early convalescence serum. So that was 10 days after illness onset for her. And that was submitted to the CDC for testing and demonstrated no evidence of viral hemorrhagic fevers via serology or virus isolation. The patient was eventually discharged with unknown diagnosis. No one knew what she had, but she had a really prolonged recovery, had ongoing abdominal pain, fatigue, and this persistent mental fog. And so thinking about this, how do we diagnose viral hemorrhagic fevers? It's something I think we aren't really taught about, and something that is interesting to think about in her case. So diagnostics for viral hemorrhagic fevers. So Traditionally, viral hemorrhagic fevers have required a biosafety level 4 reference laboratory. So there are a few of these laboratories in the United States, the CDC being the main reference laboratory, but there's also Rocky Mountain Labs where I used to work that has a BSL-4 laboratory that studies these viruses, as well as there's the Needle at Boston University, and then the NIH in Maryland at USAMRIID, the military research laboratory, has BSL-4 capabilities to study these hemorrhagic fever viruses. Culture of live virus was kind of the gold standard. So culturing virus and isolating it, that was always considered the gold standard for these emerging pathogens. But now are kind of being replaced by polymerase chain reaction for rapid diagnosis. This really took off during the West African Ebola virus epidemic in 2014. And as we know with SARS-CoV-2, that these RT-PCRs can be developed really quickly. So reverse transcriptase polymerase chain reaction, this is for RNA viruses. All of these emerging zoonotic viruses are RNA viruses. So they'll all undergo an RT-PCR, like the diagnostics that we use for SARS-CoV-2 in the hospital. There's also nested RT-PCR, which was developed to improve sensitivity, but can have issues with contamination, false positives by the way that it's run. And then there's kind of exciting new diagnostics like next generation sequencing, unbiased metagenomic sequencing that are becoming a little bit more popular, where you can take a sample and then kind of do a shotgun approach to see if there's any pathogen that might be there. Also thinking about serology is important. So ELISA for antibody detection, thinking about IgG, which is the more kind of prolonged antibody that would present later on, versus IgM, which might appear more quickly, but then might fade. Not as helpful during the acute phase. And that's why getting kind of a convalescent phase later on sample is important, and it lacks specificity to cross-reactivity. I think that this is definitely true for a lot of the filoviruses like Ebola virus, as well as coronaviruses. And there was a lot of confusion about this early on in terms of developing serology to test for SARS-CoV-2. Just thinking about diagnostics in general for emerging zoonotic viruses. So I've just put here kind of some of the main viruses that have caused pandemics, over the last decade. So thinking about hemorrhagic fever viruses, things that you would want to think about in terms of particular exposures and presentation. And as you can see, the RT-PCR kind of being the rapid diagnostic test of choice, but virus isolation if it's possible. Arboviral diseases, having kind of this more tropical exposure, although given climate change, we're seeing more arboviral diseases move north. The extension of the range of chikungunya and West Nile virus have been traveling north due to climate change, as well as Lyme disease has changed in terms of its spread, other arthropod-borne diseases, respiratory viruses. So thinking about sick contacts, nosocomial hospital-acquired outbreaks for these illnesses as well. So going back to our patient. So 6 months later, sorry, this is a little glitchy here. 6 months later, another tourist from the Netherlands visited the same cave as this patient. It's called the Python Cave in Uganda, and they died of Marburg virus infection. Our patient, so we're in Colorado is where our clinic was. The patient requested repeat testing. She was found to have anti-Marburg virus IgG by ELISA. This prompted additional testing of archive day 10 serum, which was positive for Marburg virus by nested PCR, which we talked about. So what would have been your public health response? So thinking about this, what could you maybe have done in the primary care clinic up front or in the hospital setting? And then how now with this information would you interface with public health to make sure that other people aren't infected? And so clinicians really play a key role in outbreak response. And I think it's something that we don't often talk about, but we should think about implementing appropriate infection control measures. So for viral hemorrhagic fevers, this means getting the patient in a negative pressure room if you suspect that they might have a viral hemorrhagic fever, and making sure you're wearing appropriate PPE. So this would be full PPE, eye protection, a respirator like an N95 mask or a PAPR, full gown and gloves. Many of the viral hemorrhagic fevers have a really high mortality and are transmitted primarily through contact with bodily fluids, but there is some evidence that there can be maybe droplet transmission as well, or if there happens to be aerosols generated, that there's potential evidence for maybe transmission that way as well. Pathogens with pandemic potential, such as hemorrhagic fever viruses, should be reported to your local health department. So the Washington State Department of Public Health has a great kind of website where they have all their reportable diseases. I've used it a couple of times just for reporting foodborne illnesses and things like that, but there are other things that are on there that are mandatory reporting that you should check out. And then the CDC Special Pathogens branch is really the branch that is the one that will be doing the investigations for patients that might have this, and the ones doing the diagnostic testing, so getting a hold of them. And they can do further contact tracing. Marburg virus is primarily transmitted through contact with bodily fluids. So thinking about close contacts, healthcare workers, lab workers, those who might have been at risk of exposure to the patient are really critical to think about. So the CDC notified the WHO and the Uganda Ministry of Health about the case. The Python cave was closed to visitors since the previous death. They did a contact tracing protocol and identified 260 contacts. So a lot of healthcare workers and lab workers who had exposure to this patient, which makes you really realize how, one case, how many people could be involved. Luckily, no severe febrile illness was identified in any of these contacts. But how was this patient infected with Marburg virus? Anyone have any thoughts about that?
Bats?
Bats. Yeah, it's always bats. So sorry, the key is in this photo here, and you can see him in the cave there. So Marburg virus is a single-stranded RNA virus. It's in the family Filoviridae, so it's a filovirus like Ebola virus. Has a high case fatality rate, so up to 90% case fatality rate. So this patient was really lucky to survive from this. It has a similar disease to Ebola virus. Its reservoir is a bat, like is suspected for many of the Ebola viruses. Its incubation period is 2 to 21 days. So again, that 21-day cutoff that we talked about earlier is really important to think about. And the disease presents in 3 phases. So there's a generalized phase. So that's kind of the flu-like initial phase, the organ phase where you're having neurosymptoms, vascular permeability, kind of like our patient was having these neurological symptoms. And then the late organ phase, DIC, shock, multi-organ failure, which she was showing some of, but was lucky to recover from that. And this is a picture of Marburg virus that some of my colleagues took at the NIH. As you can see, it looks a lot, if you've seen pictures of Ebola virus under electron microscope, it looks a lot like that, kind of this 6 sort of shape. So Marburg virus was first detected in 1967 after outbreaks in Marburg, Germany. That's why it's called Marburg virus. It's interesting, there's actually a lot of German scientists who study this virus because of that history. There were some scientists who imported African green monkeys to study in the laboratory setting, and they had Marburg, and a bunch of people were exposed, and some people died from it. And there have been multiple outbreaks in Uganda, Angola, the Republic of the Congo, and Kenya. There was a large one in Angola where like over 300 people died in 2005. And then there actually, I don't know if people saw this on the news, but there was a case detected in Guinea in August of this year, which was really concerning because primarily these cases have been seen kind of in East Africa, except for Angola. But to see a case in Guinea actually where Ebola virus emerged in 2014 was really concerning given the size of the 2014 Ebola epidemic. Luckily, there were people who've been in mines, working in mines or being in caves. And the Egyptian fruit bat, so Rosetus aegypticus, is the reservoir host. And humans are often infected by contact with inhalation of contaminated guano or coming into contact with bats. They've also found the virus in bats in West Africa. So there's probably a larger distribution of this virus than we previously thought. And then human-to-human transmission, usually through bodily fluids, fomite transmission. There's also suspected sexual transmission. So we figured this out for Ebola virus during the West African epidemic, that male survivors can have Ebola in their semen and can transmit it even a year afterwards. And a lot of the most recent cases of Ebola virus have actually been from human to human transmission, so delayed sexual transmission versus contact with bats or emergence from wildlife. kind of thinking about the cycle of this virus, there's a really interesting end-zootic cycle. So how the virus kind of survives within the bat populations. It doesn't cause any disease in the bats. And it seems like there's this birthing pulse where the bats give birth to their pups. And after that birthing period is when there's the highest prevalence of virus. And that seems to be like when people might get exposed. But it's maintained just naturally in these bat populations. And then from there, bats might come into contact or indirect contact with other primates that humans might be exposed to, or humans might come into contact with the bats. So thinking about ways in this human-animal interface, how do we reduce exposure to bat-borne pathogens like Marburg virus, Ebola virus? So avoiding being in caves and mines, wearing appropriate PPE, and then reducing human-to-human transmission is really important. So hand washing is so critical and something that can be really limited in certain settings where these viruses occur. Isolation, proper safe burial practices, and then safer sex for survivors. There's a ton of stigma that goes along with these diseases. And so figuring out the best way that we can kind of help survivors going forward is really important and critical to think about. So in terms of zoonotic outbreaks, I think there's a couple of things that are kind of important to think about as a clinician. And one of the things is that we play a really important role in detecting these initial cases. These initial cases of Marburg, Ebola, SARS-CoV-2 are picked up by us in the clinical setting. And so we are really need to be thinking about how do we detect these sentinel cases that might be more representative of a larger ongoing outbreak. And one of the ways I think that we can think about this is this kind of framework that I developed, thinking about the spectrum of zoonotic disease emergence. So spillover occurs when one pathogen jumps from one animal to another, so from a bat to a human. But spillover really varies by pathogen. There's some pathogens like Ebola virus that very rarely jump into people, but when they do, they have the potential to cause a massive outbreak because they're so highly transmitted between people. Whereas other pathogens that are zoonotic, such as Brucella, might spill over to people a lot, people who are having contact with animals, but aren't as readily transmitted person to person. And so thinking about if you're detecting one of these diseases, kind of where they are on the spectrum. If you're, picking up the first case of Ebola, you could really prevent there being, a massive outbreak. Whereas if you're seeing lots of cases of brucellosis, then you might think, well, maybe there's kind of an ongoing epizootic event in animals, and lots of people are being exposed that way. And so I think it's interesting to think about this. In terms of planetary health and hemorrhagic fever viruses, so increasing globalization, travel, contact with wildlife, all these things kind of come together to create this nexus that poses threats for future epidemics of viral hemorrhagic fevers and zoonotic diseases. 5 of the 6 public health emergencies of international concern are emerging zoonoses. So this is going back to the Ebola epidemic of 2014, the influenza H1N1 epidemic 2009, the Ebola outbreak in the DRC 2018, COVID-19, and then Zika. So those were all zoonotic diseases. The one that isn't is the polio epidemic. Viral hemorrhagic fevers are highly contagious, high case fatality rate. So thinking about isolation and your PPE is so important. Having a high clinical suspicion, like you guys were all thinking about these things and thinking about a good detailed exposure history for diagnosis and contact tracing. But then realizing that access to rapid diagnostics, especially in the areas where these viruses are emerging, remain limited. And so thinking about the equity issues there and the kind of additional need that we need to help with infrastructure and getting access to these diagnostics. I mean, we saw this with the emergence of COVID-19 in terms of issues with rapid diagnostic tests here in the United States. And this is a problem globally. So this case was a real case of imported Marburg hemorrhagic fever in Colorado in 2008. All the data that we had was from this CDC MMWR report on this case, which is interesting to read. And that's why there were certain things like there not being a rash and things like that. Those are the things were left out of the report. So we don't really know that data. Yeah, this was a real case with all the real labs and everything like that. And it was a pretty scary thing that happened. More details on Marburg virus, if you're interested, or just travelers' health in general, are available at the CDC website. It's a good resource to check out. And these are some references that might be helpful. The New England Journal of Medicine has a good approach to fever and returning traveler that I adapted for this, as well as some of these other resources here, some by colleagues working on Marburg virus that might be interesting for people to check out. as well. And then thanks everyone for listening to this. I would love to, if there are any questions, to answer those. And I really hope for some of your feedback on this too. This is a project that we started, and we're hopefully trying to make this into something that can be helpful, for residents and as well as medical students. And so when you guys do your feedback, if you can just, if there's any thoughts about whether this is helpful at all or interesting, what about the format? This was kind of adapted for a, academic half-day morning report style session, but we also have these self-guided cases. Are things like that interesting to you? Are there other topics you'd like to learn about in One Health or Planetary Health? And if you're interested at all in any of these or being part of this or anything like that, feel free to email me. There are lots of different kind of areas of this that we can explore. So thanks everyone.
Awesome, Seth. Yeah, so we have a few minutes for questions if anyone has specific questions about the case or about this work in general. I had one question, Seth. Maybe it's not specifically related to this, but the advent of the mRNA vaccine and how you think this is going to change the scope of viral hemorrhagic fevers, if it will.
Yeah, no, that's a great question. I mean, the kind of the increases in vaccine technology, I think are really promising. I think the big concern is how do we develop these in a kind of preemptive way? When I worked at the NIH, they had developed an Ebola virus vaccine like 20 years ago that seemed like it worked pretty well in animal models. And then the epidemic emerged in 2014, and there was this huge delay in terms of like getting FDA approval, eventually, that now there is an FDA approved Ebola virus vaccine, but seeing how long it took to go through all those steps to get there was really discouraging. I think it was pretty amazing with SARS-CoV-2, how quickly they were able to get the vaccine and get it approved. And so I think that's promising, but I think there has to be some sort of impetus to do this in a more of a preemptive way. We know about these pathogens like Nipah virus, Marburg virus, like we should be developing vaccines for them and have them, kind of as a stockpile in case these things do emerge. But there's groups like CEPI that are working on this. And so, hopefully there'll be more impetus for that.
There's a few more questions in the chat. Are you able to see them, Seth?
Oh yeah, let's see. For those of us who don't see returning travelers often, I'm wondering if you have a favorite clinical resource to review the indicated workup and questions asked based on symptoms, travel location, et cetera, in these patients. I find review these differential diagnoses, but I forget them. Yeah, that's a great question, Jordan. I really like that New England Journal article, and I can send out those resources. That has a pretty good framework that they use for that I really like. For geographic exposures, the CDC, they kind of have their yellow book when you're thinking about, kind of pre-travel, like what vaccinations and things people might need, but it's also helpful when you're just looking for the distribution, kind of general geographic distribution of pathogens. There are some other sources as well that I could include in there, and some other articles that were helpful in kind of putting this all together. So happy to share those. In terms of mortality, what protective factors did this patient have? That's a great question. I don't know enough, I guess, about the patient's, particular immunology to know that. I think luckily some of the things that the patient did have on their side is that when they returned, they kind of developed these symptoms and they were quickly hospitalized. And for viral hemorrhagic fevers, a lot of the treatment really is fluid resuscitation, blood products, it's resuscitative support. And so I think the fact that they were quickly hospitalized and were able to have those things really helped them out. Whereas if someone might, contract this in a more rural setting, they might not have those things. And that's why we see a lot higher fatality rates. But a lot of the patients, the patients who contracted Ebola, like the healthcare workers and things like that, who were brought back to the United States, a lot of them did survive because of kind of the higher level of care that we have here.
Awesome, Seth. Well, thank you all. Oh, another question.
Is there an IDE console for returning traveler? That's a good question. I don't know. I'm sure your ID colleagues would love to hear about it, though. I think that's always interesting. These are always interesting cases.
Cool. Well, we will take a 10-minute break, come back at 9:55 to hear from Sylvia Stelmacher on ECMO. So thank you, Seth. And you feel free to send the email to me or to the whole GitKu listserv.
Sounds great. Thank you. Thanks, everyone.